So revenue, as I said, was important to the physicians. We went down that road, and we had the support of Blue Cross Blue Shield of South Carolina, and they chose to pay pharmacists directly for the services provided for their patient population, as long as the pharmacist was in a collaborative practice agreement, had an employment contract, and was in a patient-centered medical home. So that helped us with some funding at first. As we grew into this, we learned that CMS was very supportive of allowing physicians to bill for pharmacist services, and there have been several letters that have been out and published. We chose to look at the practice acts of the Medical and Pharmacy Practice Act in this state to make sure we were staying within our scope of practice, and determined that we would be able to have the physicians bill for the pharmacist services, in essence, for a shared visit or incident too. That gave a big positive impact to the revenue model, and as our pharmacists began to see more and more patients on a referral basis, he came to the point where he was earning about 75% of his costs were being covered by revenue, by billing services. Now, as I had indicated earlier, we talked a lot about value. And while the physicians were thinking, well, we don't want to take anything out of our pocket to make this work, they began to realize that there were a whole lot of other values they were receiving beyond just appointment and revenue. Patient satisfaction in that practice was at an all-time high. Out of a 5-point Likert scale, it was 4.9. Patients had a lot of stories they told about their interaction with the pharmacist. There were several patient stories in which probably hospital admissions were prevented by the pharmacists that the physicians recognized. So there's a lot of very strong anecdotal stories coming out of that. When we got into the clinical outcomes, the patients that were diabetic patients that were referred to the pharmacist, Paul Fleming, 80% of them showed improvement. Now, this was improvement. These were patients who were established patients with a physician practice, post-diagnostic, referred to the pharmacist for therapy management. They saw the pharmacist at least twice, and then we had their A1Cs measured when the physicians were taking care of them, and the A1Cs when the pharmacist was taking care of them, and 80% of them improved. And they improved well over 20% of their change. So we're talking a couple of percentage points in their A1Cs. We saw very similar results under hypertension and very similar results with LDL. Again, 75 or 80% of the patients. So now the physicians who were concerned a little bit about the revenue, they're really patient-centered. And when you really talk to them, they really care about their patients. They realized there was value being brought to the outcomes of the patients. And this began to allow them having a pharmacist on board. It actually increased their productivity, the physician's productivity. And the reason behind it is they had been involved in doing some of the medication training for these patients. And they no longer did that. They delegated it off. So they were able to spend more time with other patients. They were able to open up some appointments on the schedule. And interesting enough, it increased their revenue that offset the unearned revenue of the pharmacists.